Hello everyone, welcome back on Meds. I'm your host, Mr. Meds, aka King Meds. Inkosi Yamakambi, Bonani Boti Zaneza. It's the beginning of the year, so this means new financial year for most medical aid. Most people will be switching medical aids and some will be joining new medical aids for the first time. Premiums are going up, but the benefits offered by medical aid seems to be going down. A lot of people are getting frustrated because they don't understand how medical aid works. Most medical aids offer plenty of benefits, and to maximize those benefits, you must understand how the medical aid works. So today I want us to discuss how medical aid works. Obviously, this is going to come from my experience as a retail pharmacist. Each day I deal with a lot of medical aid claims, so this video will be based on my experience as a retail pharmacist. I'll not be able to tell you about in-hospital operations because I do not have relevant experience in that category. Before we go further, it is important to note that medical aid are different. However, there are similarities. Before you join a medical aid, you must read and understand their plans and benefits. Like car insurances, medical aid can be tailored to meet your needs. Medical aid are regulated by a regulatory authority called Council of Medical Aid Scheme, which is CMS in short. Medical aid operate under a Medical Aid Scheme Act 131 of 1998. To make sure all medical aid provide customers with equal benefit, they created a list of conditions that a medical aid must cover. These conditions must be covered by medical aid regardless of your state of funds or a medical aid option. This means if the customer suffers from one of these conditions, the medical aid must pay for ambulance, hospitalization, and medication without requiring a customer to pay. So the PMB list includes any life-threatening emergencies like your car accident or heart attack. And then there is a set of 271 diagnoses that the medical aid must cover. And then there is also like 26 chronic conditions that the medical aid must cover as well. I won't get to the list of 271 diagnoses because if I do that, we'll spend the whole day trying to discuss. But in most cases of these diagnoses, the medical aid must pay for hospitalization, medication, and aftercare if required. For example, one of the 271 diagnoses that was recently added is COVID-19. If you are hospitalized due to COVID-19, then your medical aid must pay for your hospitalization, medication, and aftercare if required, regardless of your state of funds or medical aid option. As I said, we won't dwell much on the 271 diagnoses. Today I want us to discuss the 26 chronic condition list. The 26 chronic condition list include 26 chronic conditions that have to be covered by medical aid regardless of your plan or the state of funds. So this includes your chronic renal disease, Addison's disease, asthma, bronchitis, cardiac failure, cardiomyopathy, chronic obstructive pulmonary disease, your coronary artery disease, Crohn's disease, diabetes insipidus, diabetes mellitus type 1 and type 2, dysrhythmias, epilepsy, bipolar mood disorder, hypothyroidism, hypertension, glaucoma, hemophilia, ulcerative colitis, systemic lupus erythematosus, schizophrenia, rheumatoid arthritis, Parkinson's disease, hyperlipidemia, and multiple sclerosis. So if you count these conditions, because this is from the CMS website, if you count these conditions, you'll find out there are 25. But if you check at diabetes mellitus type, there is type 1 and type 2, so that count is 2 conditions. So it makes it 26 conditions on the list. So how does the medical aid decide which medication to cover for each condition on the chronic medicines list? Medical aid basically uses the treatment guidelines when deciding which medication to cover. However, the CMS created like a treatment algorithm. You can find it on the CMS website of each of the 26 conditions. To show you how this works, I'm going to use 2 of the 26 chronic conditions as an example. So the first example I will use is hypertension. Let's go to the algorithm of hypertension and see how it works. So before prescribing any medication, the doctor has to follow this list for during diagnosis process. So they have to measure the blood pressure in a sitting position. If the systolic pressure is below 130 and diastolic pressure is below 85, then you can come and recheck after a year for another diagnosis, so you don't get to start on medication in that case. And then if that's not the case, your blood pressure is above 130 and 130 over 85, then they have to check other conditions, so that they check diabetes and congestive cardiac failure, which is CCF, sorry. They'll check those two conditions. And if it happens that you have one of those two conditions, then you will have to start on treatment. If you don't have those conditions, but your blood pressure is above 160 over 100, then they have to start on drugs. Same time, start on drugs. But if your blood pressure is over 130 over 85, but below 160 over 100, then they will have to recheck your blood pressure within 2 months. And then if it's still the same after 2 months, then they will check the target organ disease. So if there's no target organ disease, then they will have to you will have to do lifestyle modification and then get a review in 6 months. But if after 6 months it still stays like that after modification, then they will have to start you on the treatment. But if also you have target organ disease, then they will have to start you on treatment as well. So if you your blood pressure just remains high and you don't have any other comorbidities, then they will initiate you on a treatment. So for uncomplicated cases of hypertension, as you can see, they will initiate you on diuretics. So the first thing they'll give you is like water tablets. It can be your Rydec or indapamide, depending on the doctor. So they will start you on diuretics mostly. But depending on the doctor, some doctors might start you like on other drugs. It will be a doctor's doctor's decision. So if there are other compelling indications, then they might have to start you on different medication. For example, if you have angina, the doctor has to put you on beta blockers and calcium channel blockers. And then if you have prior myocardial infarction, then they'll put you on beta blockers and ACE inhibitors. So beta blockers will be like your atenolol, your propranolol, bisoprolol. So those are all your beta blockers. And then channel calcium blockers will be your amlodipine, nifedipine, and lecardipine. So those are your channel calcium blockers. The thing you should note in these guidelines is that the drugs they put in class names. They don't put in exact drug names, you see. So they put class names. So within each class, there's different drugs you find within each class. As I said, with beta blockers, there's a lot of beta blockers, calcium channel blockers. There's a lot of those channel calcium blockers as well. And then post myocardial infarction, then beta blockers or ACE inhibitors, heart failure, ACE inhibitors, beta blockers, diuretics, which is going to be a furosemide or spironolactone. And then if there's left ventricular hypertrophy, then they have to start you on ACE inhibitors. If you have stroke, then low dose of diuretics and ACE inhibitors. Type 1 diabetes with proteinuria, then they will initiate you on ACE inhibitors, usually in combination with diuretic. And then type 2 diabetes with microalbuminemia, then they will start you on ACE inhibitors or angiotensin receptor blockers. This is usually in combination with a diuretic. And then it comes to type 2 diabetes without proteinuria, then they will initiate you on ACE inhibitors, usually in combination with diuretics. And type 2 diabetes with proteinuria, then they will initiate you on ACE inhibitors or angiotensin receptor blockers, usually in combination with diuretics. If there is isolated systolic hypertension in elderly, then they have to start you on diuretics, preferable low dose thiazide, which is your Rydeck. Thiazides are your Rydeck, and then long-acting calcium channel blockers like your nifedipine XL, that is a long dose. That is like a long acting calcium channel blocker. In prostatism, then they will add alpha blockers. That is, if you have maybe a prostate problem, then they will also add like alpha blockers. You see on these guidelines, they are not specific on which drug, they just put classes of drugs. So this is where the medical aid usually gets you. You'll see when I'm doing on my next slides, what I mean. So usually they will have to start with low doses and titrate up. So they will start you maybe on 5 milligrams of amlodipine, then they will titrate according to response. If the response is not adequate or you have adverse effect, then they will have to remove that drug and add another one until they get it right.